So I'm going to kind of waver a little bit in this talk a little bit about some of the things you've heard about nutrition and exercise, but I think why we have to be as urologic specialty, not just penis focused, prostate focused, bladder focused, but kind of men focused and a whole body. So indulge me a little bit, but I'll talk to you a little bit about, I think, the way we have to conceptualize. We've talked about men's health, but that includes how we diagnose and how we evaluate patients. Great. So this is a slide that you may have seen a lot of, where more people around the world are going to be over the age of 65, classic BPH patients, prostate cancer patients, and there's going to be a lot more of them. Not sure. As I'll show you now, because we always have this assumption, like real estate in New York, that it's going to keep going up the prices. It's not exactly true. The same thing with age, that people will get getting older and older. Not exactly true. And I'll show you some data. For the first time in the United States, mortality actually went down. Excuse me, the life expectancy went down. And given diabetes, obesity, a lot of other environmental effects, I'm not so sure that this train of people just increasing in age is going to actually happen. So I'll show you that in a few moments. So the mortality rate for white men and women in the United States between 45 and 54 increased a lot. There's a lot of interesting socioeconomic factors that I'll show you in a couple of minutes. This is the first time we've ever seen that in the United States in our lifetimes, where groups of people are actually dying at an earlier rate than they did the year before. So this is kind of a demographic of this over the last kind of 20 years. So that red line is these white folks in the 40s and 50s who are dying at an early age, and that's in the United States. So this is a change in ages. Let's take a look at this group. So this group, and the reason they're dying or dying earlier, a lot of it has to do with suicide, lung cancer, some of these poisonings, chronic liver disease, alcoholism. And again, I'm not going to get political here, but a lot of these are the types of folks, job issues, economic issues, and this is really a manifestation of their lives, and it's actually affecting how long they're actually living. This is kind of the age groups, and you can see that for you'll see the third line where actually rates have begun to either level off or decrease. So what does that all mean for us? So I think you've heard a lot about testosterone, you've heard about prostate cancer, you're hearing a little bit about BPH. These things are all related. We tend to put these in boxes, and we treat people, not boxes. We treat people, not glands or organs, and we sometimes forget that. And I think it's very important, and you heard from some of the case presentations, that there's a person behind all of this. And I think we have to take a lot more holistic view to the way we actually interact with patients. Whether we like it or not, there's a lot of data out there. A lot of the data is actually not that good, and that's part of the problem here. But I think we have to think of ourselves, in a sense, as it's a little consumer-driven. The difference is we're not selling Chevrolets, so the consumer isn't always right, and we have to give the best advice, but we have to remember that there is actually a person behind all of that. And educating them, I think, urology and medicine has not really used technology very well. We're very good at technology with procedures, but not using an integration of technology with enhancing delivery of information and in fact, care. Do you know that in most hospitals, for example, if you ask a nurse where the patient is, they don't know where the patient is? There's no mechanism, there's no tracking of that patient. They don't know how much interaction they have with the nurse, how much they have with other staff. It's amazing, actually, how we don't use these types of things that we use in sports and other spheres of our lives that we don't use in health. So, for another talk. So, we have to kind of rejigger ourselves. Now, this is a statue of David by Michelangelo. It's in Florence, and obviously that was the ideal version of a man. Obviously, if Michelangelo was alive today and was asked to make this statue, it would look like this. And a lot of it has to do with this. Western food, westernized food. It's interesting. And again, not to be conspiratorial, but think about this. Ever since we talked about high fat being bad, people got heavier when they went to lower fat diets because all they did was eat sugar. And it's amazing, actually, the rates of obesity, which I'm going to go through in a couple of minutes. It's striking, it's alarming, it's the biggest health crisis we have in our country, by far. It makes smoking look to be actually nothing. And in fact, one could argue that a lot of this is driven by the food manufacturers. They know that sweet drives hunger. Sweet drives more consumption of food. NutraSweet and Splenda and all those things actually drive hunger, and you eat food faster. It's an amazing concept, and I think over the year, as more and more data comes out, we'll see that this is kind of pushed. And everywhere westernized food has occurred, people got fatter. Whether it's Beijing, whether it's New York, whether it's Scottsdale, it's a phenomenon that we've seen. And this is something we've recognized for the last 15 years, or 20 years. It's nothing new. I think this came from 2003. This is a cover from the NERI group, who've done remarkable data in Boston. We've been privileged to work with them on some studies. So I'm just going to very briefly show you how fat we've gotten. So this is the first time that the CDC started looking at data. And essentially, the colors represent the percentage of adults who are obese, not overweight, obese, okay? So most of the country is white, and the reason is because most of the country didn't have data in 1985. The light blue is less than 10%, and the blue is 10 to 14%. So I'm just going to go very quickly through the years. The country's getting bluer and bluer. Again, not political statement. This has to do with weight. And this is 1990. Most of the country, the adults are at least 10 to 14% obese. A new color comes out, 15 to 19% of adults being obese. And you can see, and this is going to be, why Michigan? I'm not sure that happened there. But the southeastern states, this is going to be a repetitive pattern, West Virginia as well. 1995, most of the country is darker blue. Now a new category in 1997, which more than 20% are obese. Country's getting yellower and yellower. Another one, more than 25%. So you're always going to see Mississippi, Louisiana, Alabama. They're going to kind of lead the fray. Look how much of this country is now at least 20% obese adults, at least 20%. Now a new category just went back where it's 30%, and again, West Virginia, Mississippi. It's frightening how fat this country has gotten. And a lot of it is also driven by ethnicity. So this is whites, blacks. The crisis of obesity in the African American population is of historic and incredible. This is really bad. And you can see this whether you're in New York City or any other parts of the world, or any other parts of the country. It is really choking that population. Diabetes is on the remarkable increase as well. This is the Latinos who also have this problem. A lot to do with diet, but also economics. Single motherhood, where it's cheaper to buy a Big Mac than a salad. And those are the factors we have to deal with. Everything, we tend to isolate and silo things, but everything has downstream impact. And this is also urologic impact, if you will. That's kind of a look for these other ones. This data continues. This is 2013. It was a different way of evaluating the data that the CDC uses. The country, again, as I said, is getting more and more obese. Now, this is a Gallup poll, and another way of looking at it. But if you look at the I think it's the dark green, which is overweight, and the light green, which is obese, essentially 2/3 of the country, 2/3 of the United States are either overweight or obese. 2/3 of our country. And this cardiovascular, diabetic, and as I'll talk to you in a few minutes, urologic issues as well. Now, this is not just a urology issue. The number of knee replacements has virtually doubled over the last decade. And if you speak to orthopods, they'll tell you it's because people are fatter and they're just putting more pressure on their joints. So this is something that affects virtually every specialty. So this is a sort of a landmark study about what's going on, in a sense, around the world. So in 2014, this is the percentage of adults who are obese, and it's projected that in 2025, more than 1 billion people around the world will be obese. This is just looking at various countries. They looked at they looked at Britain, USA, I think Canada, and Australia. So this is kind of the changes. This is in 2014. If you look at the degrees of obesity using the similar color scheme, it's kind of getting worse. In 2025, more and more of the country is going to get, of the world is going to get more obese. And this is true for men and women. This is not just a male thing. In fact, women are getting more obese faster than men are. Maybe because they're living longer or they're drinking more Starbucks. It's unclear why, but it's interesting. The rates of growth of obesity in women is even greater. So if you look at 2014 for women, and in 2025, even in Africa, you're seeing this phenomena, particularly Northern Africa. So let's just put this into perspective. It's probably around each decade, the average weight around the world has increased by about 3 pounds each decade. That's a lot. And 18% of the world's men and 20% of the world's women will be considered to be obese. This is not just overweight. This is obese. The lowest BMI of developed countries, Japan. The highest BMI, we're out there. We lead. Actually, I think American Samoa had the highest average BMI, which is why they've become offensive linemen in the National Football League. There's a lot of big fellas there. Morbid obesity. It's projected that there'll be about 55 million adults who are morbidly obese. So this is kind of the lead investigator putting this into context. Now, I'm not going to give you the answers to this. This is a very complex social, economic, political issues. But the reason I bring this out is not that you shouldn't enjoy your lunch, your dinner today. I hope I haven't ruined your appetites. But I think the point is that we as urologists are affected by this as well, both personally, but also by the type of patients we take care of. So we have to become a little bit more aware of nutrition. You've heard it this morning. Whether it's for prostate cancer, whether it's for BPH, whether it's for sexual function, these issues are becoming very, very important. You have to have at least some degree of being able to discuss it with your patients. I think it's important. Exercise. We talk about exercise. Yeah, go out and exercise, but have a little bit working knowledge of some of this stuff as well. And I think for us as urologists, if we are going to be the leaders in men's health, then for God's sake, let's be the leaders in men's health. And that just doesn't mean what's your PSA and what's your testosterone. There should be more than that. And I think the more holistic we are in terms of the information we bring to patients and delivering some of this, I think we're doing a better service to our patients as well. There are other factors, sleep apnea, and that's one of the leading causes of nocturia. In fact, just as an aside, a drug got approved a couple weeks ago for nocturia, or secondary to nocturnal polyuria. They're looking for a partner to market it. So we've been involved with that drug. It's a company called Serenita, and I think it's a kind of a refined desmopressin, but it actually can have an impact once this drug will be marketed. So that's something else. Stress, huge. In New York particularly, I can tell if the stock market's down, but I get all these calls of patients with pelvic pain, women with pelvic pain. I don't even have to watch CNBC or Fox Business. I can kind of get all that stuff. So we've done actually a study, even using a mouth guard, which reduces grinding, can improve urination. So there's a lot of factors that we didn't even think about that actually can affect the way, we right away would give them Flomax. But there's other factors, and I think it just requires maybe another 3 or 4 minutes of conversation with the patient. So getting to my original topic that I was asked, so I don't treat prostate cancer. I diagnose a lot of it and then send it to my colleagues for therapy, but I don't treat a lot of it. So this was a study, though, because I do have a lot of experience with 5-alpha reductase inhibitors. In fact, we were there, I'm ashamed to say, almost at the beginning. When Liz Stoner presented, and Liz Stoner was the medical lead from Merck, and she presented this at the AUA in Toronto, actually. So last time that the AUA actually was in Toronto. You would never obviously see that today, that some medical lead would present the phase 3 data. But when this drug came out, and it's had a tortuous route in urology, it was kind of interesting from the BPH side looking at the prostate cancer side, because I never kind of thought that this drug would be a prevention for prostate cancer anyway. So I had a kind of a different view of this because I was looking at the BPH side of it and the effects that it actually had on PSA. So what we've done, we did this study, and we still continue to use this, is that patients who have had a single biopsy and their PSA continues to fluctuate. And the most common reason why patients' PSA fluctuates is just inflammation of the prostate. So we actually used 5-ARIs and found that to be kind of a good stressor, if you will. So patients, as we know, these who've had previous negative biopsies, what do? Now we get MRIs in a lot of these patients, and they do MRI-guided biopsies, but a lot of these patients wind up having negative MRIs anyway. So we thought that the change in the magnitude of a PSA drop on a 5-ARI would be more predictive of whether or not a patient actually had cancer. So, in other words, eliminate the BPH background noise that was driving PSA. So we looked initially whether it changes in a nadir PSA, and this study was published about 6 or 7 years ago. If a nadir PSA after a minimum of 6 months of a 5-ARI was more predictive what would happen on the prostate biopsy. So this was about 270 some odd men with previous negative biopsy, and they were put on either finasteride or dutasteride. This was a kind of prospectively. And in phase 1, which was about 100 patients, we measured the PSA at 6 and 12 months, and by protocol, we biopsied everybody at a year, and then we ascertained what we call the nadir PSA velocity. And in phase 2, we only biopsied patients if they had a PSA velocity change of 0.4, as opposed to the classic one that Ballantine Carter did for patients who had not been on a 5-ARI. So the mean age was kind of typical. The mean number of negative biopsies in this group was about 2.3. This was their baseline PSA and baseline prostate volume. So in phase 1, this was a patients who previously had negative biopsies. Almost 30% of them afterwards had a prostate cancer, but all of them had a minimum PSA velocity of at least 0.4. So nobody had less than a PSA increased velocity of less than 0.4. So looking at this way, 27 had cancer, 70 did not, and with less than a PSA nadir of less than 0.4. So using that as the trigger for a biopsy, in phase 2, about 27% of patients underwent a repeat biopsy, and of those, half of them were found to have cancer. And of those, the majority were having a Gleason score of 7 or higher. So using this, we were able to more predict which patients needed to be rebiopsied. Again, this was the pre-MRI sort of phases. The vast majority of these patients wound up having a Gleason 7 or higher tumor. So again, looking at the numbers here, look at the change in PSA in phase 1, and in phase 2 it was about the same. And the change in prostate volume was a little bit, as you'll show, the difference in prostate volume and PSA change is different in men with prostate cancer and those who actually didn't have it. So this was the number biopsied, the number of prostate cancer detected. Gleason 6s was much higher in phase 1 because we biopsied everybody. And we were less likely to find Gleason 6 using that PSA velocity of 0.4. Now, philosophically, that would mean, and this was in line very much with what we found in the reduced study, in the PCPT study. See, I actually have always believed that a 5-ARI could help you find the cancers you need to find. So Gleason 6s, they sit there, who cares? And that's why the PSA didn't really drive up. But if you have a cancer, a Gleason 7 or higher, that's going to drive the engine. And that's going to override, if you will, the 5-ARI. And we found this very consistently. You know, we've not missed anybody. I have over 750 patients who we follow, not just on with prostate cancer, but on 5-ARIs. And they're relatively stable. And, you know, we've never had a patient with a stable PSA, a nadir PSA, all of a sudden was found to have a bizarre cancer, unless their PSA went up. Then you're going to find the 8s and the 9s. Not that the finasteride or dutasteride caused it, but helped us to find it. And I think for a lot of those patients who have large prostates with inflammation, that's the drive behind it. Now, you can get an MRI too, but a lot of these patients have a lot of urinating symptoms, so it's part of their therapy. So that was kind of our thought process behind it. You look at the change in prostate volume, the look and change in PSA. It's different for patients who had cancer and those who did not. So that's the detection rate, looking at Gleason 6s and Gleason 7 or above. Okay, so finally the last 4 or 5 minutes, because I know you've been very patient sitting through all this stuff. And I know I'm preaching a little bit to the choir, but men's health. I think that it's not just a concept. You know, there are ways to monetize it, and you can do all that. But I think if we are going to survive as a specialty, we have to really think more holistically. And I think those centers that do will win. Now, it's interesting, over the last, having started the center at Cornell and now trying to reproduce it at Mount Sinai, I get asked to go to a lot of different places around the country to help them build men's centers. So Cleveland Clinic and Baylor, I'm going, I think, in a couple of weeks to help them build it, University of North Carolina. A lot of places are doing this. Some of the LUGPA groups are beginning to develop this as well. And I think it actually works. And not only does it work, I think it's important for us because patients, I think, come in with a lot of disarmed data. You know, if you Google prostate cancer today, it's about 89 million hits. 89 million hits. I would say most of them are probably not that good. So for us to educate is going to be important as well. For us to look at patients as more than just their prostate is important. You've heard, you know, some of the cases that Abe presented where there's a person behind all of this. And I think we have to look at preventive care being more holistic and offering these services. It's not just mumbo jumbo. It actually works. And from a business perspective, I think also works very well. And I think we have to kind of think more than just urinating and sexual function. But it does take work, and it does take effort, and it does take a business plan. It does have a vision for this. And each of our communities may be different. What I can do in Midtown Manhattan may be different than what can happen in Gainesville or in Scottsdale or some other parts of the world. But men are men, patients are patients, prostates are prostates. And how we approach that, I think, is going to be very, very important. You also have to set kind of reasonable expectations for patients. Patients come in, they say, well, can you cure this? Can you do this? Am I going to be able to do things that I couldn't be able to do? Not necessarily. I think we tend to, which is why, by the way, the sustainability of medications is so low. You know, if you look at most urology drugs, they'll only be taking that drug about 20% of the time or 30% of the time at 6 months. So if a patient comes in and you give them a drug for urgency, they expect it to be perfect. They're not going to be perfect. They can be better. But that's on us to explain it, not just write a prescription. That's our responsibility and I think our opportunities. So is this also issues in prostate cancer? Yes, and there's a lot of studies, and you've heard it this morning, about the role of nutrition and obesity, either pre-op or pre-therapy, and I think these are very important as well. I'm just going to skip through that in the interest of time. So finally, my last couple of provocative points. We've trained a generation of technicians, frankly, and we've lost a generation of scientists. We really have. We've forgot that it's not just what robot we use and what technique we use. We have to think holistically in terms of how we do this. And if we don't, our specialty is going to be having a lot of issues. And the opportunities are there. The AUA has now funded a new residency slot, if you will, I think in 2018. Well, there'll be a urology scientist for a 3-year piece of their urology residency. So they'll have an extra 3 years buried into their clinical program that they will focus on research. I think the organizations are realizing that for sustainability of a business, whether it's the AUA, whether it's a startup, whether it's Apple, you need to have discovery. You need to move forward the ball, because if not, you're losing. And I think this opportunity for us is there. So let's take the lead on that. And finally, build innovation, quality, and trust. Have fun doing it. Urology is a lot of fun. It's actually a privilege to take care of people. And I think if we start thinking of it as a job, and more that it's a real honor and privilege to take care and make people's lives better. And if you think of medicine that way, it becomes a lot more enjoyable. Anyway, thank you very much for your time.